It's my kind privilege to welcome all of you, like Dr. Ashok Rajgopalan, one of the veteran orthopedic surgeon, and Dr. A.K. Agarwal as a moderator, is also one of the veteran expert in the medical fraternity, and Dr. S. Gulati. Dr. S. Gulati also one of the reputed sports and spine surgery experts. Today we have topic on the knee and hip and knee pain. So this is a very brainstorming topic. I hope you would, all the audience would love to join, and hear patiently our patients. So let's be hand over to Dr. Agarwal. He will moderate today's webinar. Thank you.
Thank you, Tiwari, for giving us this opportunity. And I think this is a wonderful beginning of the day after independence celebration. And the topic which we are talking is the topic of, I think, of the every house, all over India, all over world. And the topic will be covered by our stalwarts in our medical fraternity, Dr. Ashok Rajgopal, who is very well known person, the person who has perhaps given a new name, new shape to the knee joint replacement. Dr. Ashok Rajgopal is the chairman of Institute of Musculoskeletal Disorder and Orthopedic in Vedanta, Gurgaon. And of course, I know it very well that he the person who has done perhaps more than 39,000 knee joint replacement, and much more than that, more than 60,000 orthopedic surgeries. He is himself as an institution. And of course, we will be joined by our friend, Dr. Yash Gulati, Yash Padma Shri Yash Gulati ji, who is very eminent orthopedic surgeon in Apollo Sarita Vihar, New Delhi, and his contribution to the medical profession, needless to say, he has contributed so much, and I know he is orthopedic surgeon of all the VVIPs. And soon Dr. Rath will be joining us, and when he joins, I'll introduce Dr. Rath.
Sir, I'm already there.
Dr. Rath is there. Yes, Dr. Rath, thank you very much for joining. Dr. Rath is our friend from Max Super Specialty Hospital, Saket, and he is a rheumatologist. Rheumatologist is a very highly specialized branch dealing with joint, and he has more than 20 years experience, and he is supposed to be one of the top rheumatologists for our country. So with this little start, I'm going to request, before we request, the topic of today is advancement and breakthrough in pain management in hip and knee. That is very important because perhaps these two joints are the joints which maybe because of aging, but there are many other factors also. So let us ask our expert, Ashok. We are talking about the management of hip and knee. Of course, the pain is a very important factor. And I would like to ask you your experiences in next 15 minutes, that in what way the patients are coming to you as regard pain is concerned, and what is the advancement of technological advancement as regards its management is concerned.
Good morning, Dr. Agarwal, Amrish ji, my good friend Yash, and Dr. Rath. It's a pleasure and a privilege to be on this wonderful panel. first up in the morning. So this is obviously a topic very, very close to my heart. I've been in this field now for almost getting on to 40 years. And great question, Dr. Agarwal. So if you look at the patient population that comes across to our outpatients, the majority of them who have knee pains and hip pains, let me start by saying that one of the commonest issues that we see are a lot of patients who come to us with complaints of pain in the hip and knees. This may seem very, very basic, but I think it's extremely important, when we talk about the management of these patients. The hip and knee are two areas that are often the sites of referred pain. So you can have a pain in the or an issue in the lower back or in the pelvis. You can have vascular reasons, you can have neurological reasons for pain in both of these areas. And it's not uncommon. I mean, this has been frequently reported of where patients have had knee surgeries when the pathology was actually in the hip. And Yash will bear me out when I say that one of the fundamentals when patients come to us with pains in the hip and knee area, to do a thorough medical clinical examination, radiological evaluation and assessment, and get to the correct diagnosis. Clearly, the ambit of this morning's session is to talk about recent advances in the management of hip and knee disease. And so we'll take as a premise that most of the patients that we're going to be talking about this morning are going to be those patients who have had hip and knee pains, have been diagnosed accurately for evidence of disease in their hip and knee area, and have undergone a course of conservative, which is non-operative medical management, which is medication, anti-inflammatories, injections, physical therapy, braces, alternate systems of medicine like acupuncture, acupressure, homeopathy, and Ayurveda and yoga. So we're going to now start by talking about those cohort of patients or subgroup of patients who have had all of these treatments, have not responded, and their radiological evaluation and clinical assessments, and after careful discussion with the patient and their families, are being counseled for a joint replacement. So in the 15 minutes that I have, I'd like to break this up into two real sections. One is the hip area and one is the knee area. In the hip area, the commonest diagnosis that we see, particularly post-COVID, where a very large volume of our patients have been on steroids, and there's been an absolute epidemic of avascular necrosis, and sadly, the tragic situation or fallout of this steroid intake has been a very large number of patients with avascular necrosis, particularly affecting the younger population. And we're seeing patients in the age group of 17, 19, 25 to 30 who have had advanced avascular necrosis that has affected their quality of life, necessitating a joint replacement. So if you look at joint replacement on the hip side, again, if we exclude the more conservative options like subchondral drilling and attempts to revascularize these areas, you look at total joint replacements. The basic mandate of hip replacements is basically classified into hips which are cemented and hips that are uncemented. Again, there is a huge divide across the hip surgical population across the world. A vast majority of patients, for instance, in the United Kingdom, are administered a cemented total hip replacement. And for those people who are unfamiliar with these terms, cemented basically means that the implants are fixed to the bone using a glue that is called bone cement or polymethyl methacrylate. It is a combination of a liquid and a powder, which basically causes an exothermic reaction, and this becomes like a doughy material. It hardens over time in the next 9 to 10 minutes. It is dependent on the ambient temperature and humidity. And this locks the prosthesis or implant into the bone. On the socket side, again, we have a choice of cemented and uncemented. The articulations on the hip side can be the earlier articulations, which really sort of fell out of favor, were the metal on metal implants. These were hugely popular, and the best reference point I can give for that is Andy Murray, the UK tennis star who won a couple of Grand Slam titles. And he participated as recently as this year's Wimbledon championship. He's actually been playing with a metal on metal articulation. Is still available in very, very select communities, but has largely fallen out because of the large failure rate and the very high iron discharge into the system, particularly in young females. But in very, very capable hands and very select patients, it has a great outcome even today. The commonest combination is the metal head, which can be stainless steel. But most of us today will use a ceramic head, and the articulation on the cup side may be either a high-density polyethylene. Some of these are vitamin E reinforced for longevity and to prevent oxidation and give it a long-term survivorship. And a more recent option that's available is a ceramic on ceramic. This is called a hard on hard bearing. And I think it's gratifying to know that hips really do very, very well. A large volume of these patients will survive for anything between 25 to 30 years. And in our own experience, we have had patients who received a total hip replacement in early 90s, and still going strong. So done well, these do very well. We will talk about recent advances in connection with the knee implant. So knee is really the area that has exploded with technology. So knee replacements are of several varieties. Basically, it comprises of three components. One that covers the lower end of the thigh bone of the femur, the upper end of the leg bone of the tibia, and inserted between them again is that piece of high-density polyethylene, which is predominantly vitamin E reinforced. Now, the whole knee scenario has undergone an explosion in terms of three things. One is the alignment options that are available. When we started, it was pretty simple. We just had a choice of two alignments that you could choose from, and most surgeons took their pick out of the two. Today, we have a choice of 17 alignments, so it's a bit of a confusion and very, very controversial. A lot of debates on which one is the best. And clearly, when there are 17 alignments, the one thing that stands out is none of these really are as good as the other ones. So, or all of them are as good. Robotics and artificial intelligence has come into its own, and robotics is now a front runner. Robotics basically gives you the choice of being able to align the implant as per the choice of your alignment philosophy. Put very, very simply or very crudely for the sake of understanding, it is like your GPS on your Google map that takes you to your destination. So you predefine your targets, set it up to the robotic system, and it'll take you to that particular zone and will give you up to about 0.2 millimeters of accuracy. So that is what we're now able to achieve with impunity and with repetitiveness. It has made the knee replacement a more level playing field. Having said that, the real million-dollar question is, does intervention with technology, whether it's robotics or computer navigation, or I know Yash has been a great proponent of another technology that's called the eye assist, which is again a sort of a gyroscope related option. Does this actually make the patient better? I think the jury is still out. I don't think there's any universal agreement on this. What we do know is that robotics in its present avatar is at least as good, if not better. Whether it'll outlast conventional knees is going to be difficult for us to say at this moment, particularly given the fact that knee joints done well will last up to 25 to 30 years. And some of the surgeons, me included, believe that if a knee lasts 15 years and longer, it'll probably last a lifetime. So from my perspective, we have patients who are now reaching 28 to 30 years. One of I might add in this talk that my mother-in-law is also one of those patients. She's now 26 years since her bilateral knee replacement, still doing well. We just got her X-ray recently, looks pretty good. So to say that technology will improve survivorship is probably a bit of a gray zone, but it is accurate, it is efficient, it is also more expensive because of the technology costs. I think the last bit on this is the 3D printing. We're talking about more personalized alignments. I think everybody on this panel has different alignments for their knees, and it's now possible for us to tailor make the outcomes and the results of each knee replacement specific to that particular patient. Last thing that I would like to say is that we also have the option of customized implant, which means you can do a CT, a 3D CD reconstruction, and the company can actually manufacture a knee implant specific only for your dimension. These are available, so there are some companies like Conformis that do this, but obviously the costs and the timeline are prohibitive. So with that, I'd like to conclude by saying technology is an additive methodology that is available to surgeons. It is here to stay. It gives you accuracy. It gives you your desired choice of alignments, as I discussed. But whether it's going to actually outdo the conventional procedures done by a competent surgeon who understands the business is something that we'll have to wait. It'll need to wait for time to tell us. But my bet is that the jury is still going to be out, and done well, a manual will match a technologically aided knee or hip replacement and give very comparable results. I'd like to thank you all for your kind attention.
But Dr. Agarwal, I think you're muted. You're still muted, Dr. Agarwal.
Am I? Sorry.
Yes.
So thank you very much, Ashok, for this wonderful piece of information. And there comes few very leading questions in my mind that one, first of all, a remark that whether it was metal on metal or ceramic or mixed of both, it seems that the surgical hands and expertise is the most important thing, which makes the thing simpler and useful for the patient. So there is no doubt that your expertise, your experience is the of utmost importance. But nowadays, a lot of emphasis is going on regenerative medicine, and especially in hip. In knee, we are talking of PRP, etc. And there are many articles. Any brief comment on that?
Great question, Dr. Agarwal. So the one cell that does not grow and grow well is basically the cartilage. The chondroblasts are very, very difficult cells to grow. And there are multiple options. You have the PRP, you have hyaluronic acid, there is corticosteroids, there are mesenchymal cells, and all of that. I think a fair comment would be, I was on a panel, an international group panel, which discussed the relevance of these non-arthroplasty interventions. And at best, we can say that these are palliative measures. They don't really regenerate cartilage. In fact, there are instances where the amount of PRP that has actually been injected has caused a reactive synovitis within the joint, making this condition extremely painful. So these are probably ideally suited for very young patients where age precludes their need for arthroplasty. It is certainly worth trying. I can give you my own perspective. I do not inject joints at all. We've seen some absolutely catastrophic results with exacerbation of pain, with infections, and most importantly, these are palliative measures. They never really correct the pathology, because most of these pathologies, in addition to being cellular, is also a malaligned thing with inconsistent wear of the cartilage on the medial side or the patellofemoral side. And there's no available technology to date that actually addresses growth of these cartilages in the areas that are deficient, including open surgeries and stitching these cartilage harvested cells using a bit of periosteum from the various parts of the bone. So at best, the answer to your question, Dr. Agarwal, is possibly palliative, no long-term benefits, and it is unequivocally been proven that this will at best delay a more definitive defined surgery, but will not avoid it altogether.
So Ashok, my last question to you, that if there is a patient who is suffering, and being advised surgery, somehow he or she has got hesitancy, and they want to delay, what is going to be your final advice to them?
Again, Dr. Agarwal, great question, because we get faced with this challenge all the time. If the patient has a unicompartment disease, and they've come to us at a relatively early stage, you have the choice of offering them an arthroscopy that gives them up to about 1.5 to 2 years of relief. It does not correct the malalignment, but takes care of the mechanical issues within the knee. The other option is to consider doing what's called a partial replacement or a unicompartment replacement, which is just replacing the medial or the lateral compartment or the patellofemoral compartment. I have several colleagues in Europe, good friends of mine, who will do 2 joints, so they would be replacing the patellofemoral and the medial compartment, or the medial and lateral compartment. These do very well, but these are again invasive options. So basically, you try to keep them on alternative treatment options. Injections would be one indication over here, but they should be warned that you can try 1, 2, maybe 3 injections. But once angular deformities start, I think it's a matter of time before the pain gets the better of them. The quality of life suffers to a point that it's probably better for them to consider surgery.
Right. Ashok, I think before you leave, I have a very important question, which is perhaps for all 3 of you. And I would like to emphasize, like cardiac health, or we have now new chapter of knee health, right? The knee health is important, and we all know that at any age of the life or before that, we may suffer. So what is the preventive aspect, and that preventive aspect in some high-risk group? I will like Ashok first to comment, and Yash and Dr. Rath, because then you will be living and you have your...
Again, very insightful question, Dr. Agarwal. So the 3 things that I would mention here is we we have a very high incidence of patients with hypothyroidism. Hypothyroidism is a precursor to bad cartilage health and disease. We seem to be seeing more and more hypothyroid patients. The second thing, of course, is diabetes. A lot of diabetic patients also are at risk for cartilage health. And the third thing, which I was actually sort of preparing a talk for a presentation I'm due to make in the next couple of days. I was amazed to see that India is now the 6th most obese country in the world. And the obesity is the single most defining factor. And I think the rate at which we are going, I thought we would be somewhere in the 11th, 12th, but I was absolutely shocked that we are 6th in the hierarchy of the of the obese nations. And so I think it's critically important to advise these patients to have good lifestyles, try and avoid obesity, do some sort of exercise of whatever form, if they're hypothyroid or diabetics, to control themselves. And if they are able to do that, hopefully the degenerative speed or the rate at degeneration of these joints will slow down.
Yes, we'd like to comment upon preventive aspect. So I apologize because I should have come to you
No,
on
it's
this
okay.
question at the last.
No, that's all right. No issue at all. As far as the prevention is concerned, I think we have to understand that, I've seen some 130-kilo man, 70-year-old, and looks like a 16-year-old knee, and a 40-year-old person, 50 kg in weight, and an absolutely rotten osteoarthritic knee. So I think there is some element of genetics going on here, which we cannot control right now. Maybe that will be for future to modulate that. So I can't dwell on that, but I think there will be research on that. So as far as things are concerned today, I think the things which are under our control is our weight. As Ashok also said, I always give the example of a horse carrying 50 kilos and a horse carrying 200 kilos. Who will run longer and who will run for, faster. So it doesn't take any big brain to decide that. So weight reduction is extremely important. And the other thing also I always say is that, if you have a room which has some weak walls, then what you can do is strengthen the pillars. So our pillars of the joint are our muscles around it. So if you can strengthen these muscles, even though the joint may be weak or cartilage may be weak, this muscle will take the load and take us through for a long time. And another thing which can be done is modification in our shoe. Some outer shoe raise in medial arthritis. These kind of small little things can also help at times. And as far as even vitamin D has been correlated with relatively not very good cartilage health. So that also can be kept in mind. And hydrotherapy, swimming, we don't have access to pools everywhere, but those who have it, I think hydrotherapy, etc., is extremely good. And of course, managing our other medical issues important. So preventive aspect, going for walks, keeping your general health and keeping your muscles strong, keeping your joints mobile, and of course keeping your weight down and other general health, I think go a long way. And all this shoe modification in early stages. And I personally am not very fond of all these drugs which are pushed for years and years together, thinking that they will enhance the cartilage. They are of very doubtful value. Even these injections like viscosupplementation, I think of very limited value. I would try them only in some very special circumstances when other things cannot be done or in very younger age group. So I think these would be my thoughts for prevention.
Thank you. Yes, I think, Rath, I'll get back to you regarding preventive aspect because your topic is totally different. That is rheumatological aspect of these two joints. So I will request Yes to continue with his expertise and his, what do you feel is, I know you are more into robotic and all, and ever since you have adopted robotic and other technologies as regard knee is concerned, and we'll talk about the hip also. What had been your experience as regard the patient satisfaction?
The thing is, As far as I think Ashok has covered the general part and some other specifics extremely well, so I do not want to repeat them. As far as the knee is concerned, I personally am very fond of offering partial knee orthoplasty in younger as well as in older. And the results in some of the old people who are more than 75-year-old with partial knee arthroplasty have been so fantastic because this surgery is so small, the morbidity is so small. You can start walking next day, you can play golf, you can do all kind of routine activities. So this is one area of knee orthoplasty which I think is not properly understood by majority of people as well as majority of orthopedic surgeons because they are scared because they've not done many and it is documented. The results of this kind of surgery are better with people who are doing them more routinely and in bigger numbers. So this is one area which I think it has been proven in UK and in the studies in our country, which was done in Hyderabad, that up to 49% of patients who get total knee replacement will actually do well with partial knee replacement. So this is something I'm very passionate about. So that's why I spent a minute extra on that. Now coming to the robotic surgery, there is a saying in Alice in Wonderland that you have to run to be able to stand. The modern technology is here, we have to imbibe it, but we don't have to become foolish with the technology in our hand. We have to have a balanced approach. The fact of the matter is that the last so many years, the method that we have been using, the results have been absolutely marvelous. Only thing is that often it is said that 20% of patients have dissatisfaction, and that they say is probably because the alignment is not perfect. But even with robotic, the alignment sometimes you are doing different kind of alignment, which in earlier days I would have said it is malaligned, gone into, whereas now our robotic friends tell us that this is the best alignment. So as Ashok said, there are 17 alignments now. So jury is absolutely out. Robotic is a great tool, and as you know, we are doing it routinely, but let's not forget that those who cannot get by robotic surgery doesn't mean that the other method is not, is probably just as good. So there's no doubt about that. And other thing that we have to understand is that now in the modern technology, we now have many other things available to us. For example, trabecular metals, we have sleeves and cones and wedges and rods, where when there are major deformities, we are able to do surgery, and with major defects, we are able to cover them. We means every orthopedic surgeon who's doing joint replacement. So all these things are available, and as was said by previous speaker, 3D printing and robotics, it's all adding on. These are all addition. Basic thing is the driver. The driver has to be well trained. The driver has to know exactly what one is doing and what thing is required when. So that is important. Other things are just tools. Whether you're going by a car, whether you're going by, a Mercedes car, or you're going by a Toyota car, it doesn't really matter. It's the driver who's driving, and you know where the passenger has to go. So all these things are extremely important, I think. So, but we have to keep pace with technology. And as I said, partial knee arthroplasty is, I think, as a fantastic operation when it is suitable. And there are obviously conditions where it can be done and where it cannot be done. So my emphasis would be on that. Every patient who comes to me with knee pain and requires surgery, I always tell myself, why can't I do a partial knee? Why do I have to do total knee in this? If the answer is that I can't do partial, patient is not suitable, only then I will do total knee replacement. So that message I would like to be passed on.
I think it's a very important component and information you have given. Yes, I mean, let me put myself as patient, and if I come to you, obviously I have full-blown symptoms of knee, but I respect my clinician to advise me no surgery. That is my comfort. And if surgery has to be done, if you say, then there is partial knee, then total knee, I will definitely opt for, okay, if there is a possibility of partial knee, let me think about it. Please explain to me. And what are the possibilities? Will I be all right And if so, will I be all right for longer duration throughout my life?
Yeah, I mean, the thing, as I said, you can do partial knee when some conditions are met. For example, the rest of the knee is almost okay. You know, it cannot be 100%, but say if it is 80, 90% okay is fine. The outer side of the joint, for example, mostly we do medial partial knee. And if that is okay, the patella is mildly involved, especially on the inner side, not on the outer side, and the ligaments are okay, I think that's an ideally suited person for partial knee arthroplasty. And of course, you have to have a bone-on-bone arthritis on the side that you're doing. Excuse me. So if these conditions are met, please take my word. It is a superb operation. I mean, if I had to get my own operation done and I had a knee problem and I have only one compartment involved, I will not even think for a minute what I should choose, provided all the conditions are met. And the longevity of partial knee and total knee, now it has been proven, is the same. You know, and there are reports saying there which are more than 20-year survival rate of more than 90%. 85 to 90% 10-year survival rate is uniform in all the cases. So this is a different operation. Many times people try to compare the results of this with osteotomy, results of this with total knee. This has a specific indication, and this has specific. It's an operation. It's not a time buying technique. So the results are as good or even better than total knee when it is suitable. I have no doubt in my mind about that. You can play golf, you can sit cross-legged, you can, jog. This is wonderful, especially for elderly. The morbidity is so low post-operatively. It's a small little 4-inch incision, a small little, the bone that we remove is of the size of a biscuit, thin biscuit. That's all. We are not dealing with any soft tissue dissection. Very has to reach the joint. So there is no question, absolutely no question. I hope that answers the question. Can you hear me? I hope I am audible. Please raise your hand. Dr. Tiwari, Mr. Tiwari.
Now
Yeah,
I can hear you. There was some technology about 2-3 minutes. Please
all
continue.
right, okay. No, I just, so I'll sum it up for you. I was talking about the partial knee, that if the conditions are met, the longevity of this operation is same as total knee, the morbidity is much less. And as I said in the beginning also, about 40 to 49% patients who actually get total knee replacement will do better. You can hear me, Mr. Tiwari, please raise your hand because there's some, I think.
Go ahead, it's okay.
Yeah, Dr. Agarwal, there's some probably audio issue on that end. So I'll just go on. I'm just repeating what I said earlier, that this, in my opinion, one should opt for a partial knee if the conditions are suitable for partial knee in knee arthritis. If the criteria are not met, that is, if the disease is tri-compartment, meaning that all the knee is involved, then obviously you cannot do this. If it is inflammatory like a rheumatoid arthritis, then obviously the whole knee is involved, you can't do it. So partial knee is only when one compartment is involved and others are almost normal. I mean, they can't be 100% normal, but they're almost normal. Then it's a fantastic operation, no question about it.
So it's a very, very heartening to know that as a perception, as I put myself, that if I'm told, okay, the partial knee will do, that will give me some sort of consolation. And this outcome of partial knee will be as good as the total knee. And perhaps we are able to lead better quality of life.
Definitely.
That's a very encouraging thing. But okay, let me put another question to you, that what Ashok also mentioned about post-COVID scenario of hip avascular necrosis. And you too must be facing avascular necrosis cases blooming up. So are you offering them some solution which is
Yes, you
something
see, as far as yes, we have seen sudden surge in the number of avascular necrosis after COVID, whether it was the COVID itself that caused it, or whether it was steroids which were given for treatment of COVID caused it, or was there any immunological factor? We don't know. But the fact is that the the number has increased dramatically, especially in all age group, even younger people, and it is not related to alcohol, this particular type of avascular necrosis and other factors. So when these patients come, uh, first of all, we have to distinguish between avascular necrosis and idiopathic osteoporosis of the hip. These two are very different. They may look alike in the beginning because the other one is absolutely treatable with rest and it'll get better. If it is avascular necrosis, it's a very controversial subject because all the treatments that are offered have, no really long-term study which will tell you that this particular treatment is better than the other. People will go out from giving to, all these alendronates, to doing core decompression, to putting bone marrow into that, to putting stem cells into that, to putting fibular graft, to other graft, and even muscle pedicle graft, all these things. But nothing has proven to be better than other, and nothing has proven to be successful, definitely documented successful. So this is a very difficult situation to deal because some people will progress to osteoarthritis, others will not. So in my particular practice, what I do is that I try to take the least path of least resistance, as they say, or the least that I can do. The least I can do is that there is a theory that if you give alendronate initially intravenous and then oral, it strengthens the bone around that and prevents it from collapsing. It has very little side effects. Although there is no serious study to absolutely prove it, but I am doing this in my practice because it seems the results are acceptable in this. Number two, surgical intervention, especially in younger people with core decompression and putting a bone marrow. Again, it is a minimal, very small little operation. It doesn't harm the patient. It does not jeopardize any other surgery that may be required later on, because rather putting fibular graft and muscle pedicle, it really spoils the area. So this is what I would offer in early stages. If somebody has come to me, say after 8, 9, 10 months or a year, then I say, look, it's too late. I don't think surgical intervention is going to be of any help. Now you let's wait and see. And if things progress, uh, frank osteoarthritis, even then, many people are able to go on for years and say, no, I'm okay. I just take one pill a week or so. I say, carry on. If you're a young person, you come to me or come to your orthopedic surgeon only if you think of your lifestyle is getting affected and you think it's not good and you're having to take many painkillers. Only then and only then I would offer them total hip replacement. And of course, in those cases, we now, I think the gold standard has become a ceramic head with a highly cross-linked poly. We do uncemented implants in younger people, but believe me, as Ashok also had said, that cemented orthoplasty is as good, if not better, because I have my own patients for last 26 years, which have lasted with cemented orthoplasty. So no debate in that, whichever one is more comfortable with. But only and only when patient is really disabled would I offer hip replacement. And in early stages, as I said, alendronates and possibly a core decompression with bone marrow concentrate.
All right. Thank you, Dr. Gulati. Please, I will request you to continue to be with us because now I am switching over to our friend, our colleague, Dr. Rath, who is a very eminent rheumatologist. Rheumatology itself is a associated, very important branch of knee and hip and its presentation in terms of severe pain. Dr. Rath, we are talking about knee and hip joint. We are talking about the pain. And what do you think is the relationship of rheumatological intervention this particular symptoms, where you stand as regard, and where should you interfere?
Yeah. So I think this question is often asked by the patients that, what is the difference between an orthopedician and rheumatologist? And the way I explain them is the same difference between a cardiologist and a cardiothoracic surgeon, or a neurologist and a neurosurgeon. So I think as a rheumatologist, because we come from a clinical background, from a medical background, so we deal with a lot of medical disorders. And our approach to a hip and knee pain, the first thing is this pain articular or periarticular? As Dr. Rajgopal said, many a times a pain which may look like it's in the knee may not be in the joint itself. It may be periarticular. It may be coming from a bursa. It may be coming from, like a trochanteric bursitis in a case of hip, or a pes anserin bursitis in a case of knee. So that is the first thing. And the second thing is that once the foot is in the joint, the first and most important step is to understand whether this pain is inflammatory or non-inflammatory. So all joint pains are basically divided into two categories. Is it an inflammatory pain or a non-inflammatory pain? And this is the most important step, because if you miss this step, you miss the bus completely. Because from here on, the two diseases diverge completely opposite to each other. So the best way of knowing is if the patient has early morning stiffness, and this stiffness lasts for at least half an hour or 1 hour and improves as the day progresses, then this is an inflammatory pain. On the opposite of it is the mechanical pain, which was being discussed, where a patient, if they are taking rest, they are feeling better, and if they start moving, the pain is worsening. And so once this happens, and you know that this is an inflammatory pain, we come into the picture because these are young males. They can be even middle-aged males. They can be elderly males who can be suffering from conditions like ankylosing spondylitis. They can be suffering from rheumatoid arthritis. They can be suffering from polymyalgia rheumatica. I mean, I have seen patients of polymyalgia rheumatica undergoing the knife, undergoing replacement with no improvement, because his pain was actually periarticular, and it was basically because of polymyalgia rheumatica. We have patients with failed back surgeries who come to us because they have diseases like polymyalgia rheumatica. It's a disease which is unrecognized, seen in elderly people, severe pain in the shoulders or severe pain in the hip joints, and they have very high ESR and CRP, and there is no other lab test so as to call a lab test to diagnose these patients. So it's very important to first and foremost understand, is it inflammatory or non-inflammatory? If it is a mechanical pain, then of course my orthopedic colleagues have already discussed the various options. But if it is an inflammatory pain, then the first and foremost thing is to make a clinical diagnosis as to what kind of an autoimmune disease, and the misconception is that autoimmune disease affects only young males or young females, but there are conditions like gout, there are conditions like psoriatic arthritis and polymyalgia, which affect also an elderly population. So once we know it's an inflammatory pain, then we make a diagnosis and we treat them early with disease modifying drugs. And that is what prevents these patients from ending up into a joint replacement. Like patients with ankylosing spondylitis are the most common patients who end up with hip replacement, because their disease doesn't get diagnosed early. It's very late, and these are people in their 20s and 30s. And offering them a hip replacement at such a young age again becomes a difficult job, because they're going to outlive the replacement. So it's very important to diagnose it and treat it very early on if it's an inflammatory pain. So that is very important. Sir, you are, I think, muted. No, sir, muted again.
Yes, you did mention very important aspect, and that aspect is in the inflammatory aspect, and that inflammation may be directly on the joint, or there may be effect of any other involvement of the body which affects the joint indirectly. That is very important. But the point is that the patient, when are you ready to receive the patient for total treatment? When clinically you examine, number one, and number two, certain tests are being undertaken by you, and those, then you are able to differentiate, well, this is the patient you are going to treat, or this is the patient you will refer it to your orthopedic surgeon.
So, sir, one of the biggest myths is a lot of people think rheumatology is about fancy tests. Believe me, nobody knows more than a rheumatologist that most of these tests can have a lot of false positive and false negative.
Dr. Rath, your voice is little cracking.
Am I audible now?
Yes, yes. That's it.
So
Thank
the big myth about rheumatology is that a lot of people think that rheumatology is about fancy tests. Whereas rheumatologists know more than anyone else that the test can have a lot of false positivity
Yes.
and false negativity. So we
Hmm.
depend purely and purely on a good clinical history. And a good clinical history will give you the diagnosis in most of the cases. Remember this, in rheumatology, it's clinical history and nothing alone. So we know that HLA can be false positive, can be positive, and the patient may have mechanical pain. We know that HLA-B27 can be negative, ESR-CRP can be normal, and yet patient can have ankylosing spondylitis. So what is important is what I told you, is it inflammatory, is it non-inflammatory? That is the first step. If you have missed that step, you've missed the bus. And that is one question which is asked by a good rheumatologist again and again. And when we get the answer, if the patient has, so we have patients, so we know that conditions like psoriatic arthritis can present in both the hip joints and mimic ankylosing spondylitis. But HLA-B27 is positive only in 60%. ESR-CRP is often normal in psoriatic arthritis. It is very dicey. And we get patients who have gone everywhere and they say, sir, all the tests were normal. So people told us we don't have arthritis. And the patient is screaming that he has arthritis. He is not able to get up in the morning for half an hour, 1 hour. He has got. So as doctors, we do not look at the patients. We do not respect our clinical judgment. We are dependent on labs. I mean, a young male who comes with a bilateral hip pain, who has taken a high dose of steroid, and somebody does a ANA positive and it comes positive, it doesn't mean anything. The patient probably has an osteonecrosis, avascular necrosis. So these are things we see in daily life. So my thing is that we should make a clinical examination, take a good history. If it's inflammatory pain, then we must make a clinical diagnosis, because a lot of misconceptions, like I see patients of ankylosing spondylitis being given hydroxychloroquine. It has no role. So it is not that all arthritis are treated in the same way. Ankylosing spondylitis has disease-modifying drugs. We have biological drugs. We have targeted small molecule drugs like tofacitinib, where we have actually, it's very dramatically changed the way we treat these diseases, and we are now able to control them completely early on and prevent any kind of deformity happening. And the younger the patient, more aggressive the treatment, because the joint has to be preserved, because they need it for a longer time. But when it's a mechanical pain, it's a degenerative arthritis. Now, again, in our country, how many people can afford a knee replacement? How many people can, undergo PRP is sometimes very difficult. And I would agree with all my colleagues that the major problem that we see in our population is obesity. The generation which is now is very, very aware. But the generation that we are seeing in the 70s and 80s are the generations who are housewives, who are obese, who don't have the concept of exercise. For them, exercise means I'm doing my household chores, so that's the best exercise I can do. So that definitely becomes a problem for mechanical pain. But yes, for inflammatory pain, early diagnosis and treatment, we can prevent damage in most of them.
Okay. Dr. Rath, I think that has given us another clue that a thorough clinical examination, and I'm talking from patient point of view, and then the carefully taken decision regarding the medical treatment. I understand that nowadays a lot of new trials are going on as regards new drugs are concerned in rheumatology field. What do you think? Will it make a change into your scenario?
Yes, sir. So the most important thing in an inflammatory disease is not the kind of drug we use, but how early we use. So the emphasis should not be on the type of treatment that is given. Emphasis should be on early diagnosis. If there is a disease which is diagnosed early, then it can be treated with very minimal drugs and very early. And that's why if you look at the Scandinavian countries, they do not use a lot of biologicals, unlike the US people, and the burden on their economy is not high. They're using very basic drugs. But what they have done is they have early arthritis clinics. So the patients get diagnosed very, very early on. And if you get diagnosed early on, most of the patients will get controlled with very cheap, easily affordable conventional medications. But once they have missed the bus, or very few subset of patients who have refractory disease are the ones who need to go for more expensive biological treatments. So the first emphasis is early diagnosis. But yes, having said that, there was the era of biologicals, and now from biological era, we have moved to the small molecule era. So earlier the concept was to block the inflammation outside the cell. Now we are blocking the intracellular signaling pathways by the JAK inhibitors. So these drugs act at intracellular level between the cell membrane and the nucleus. Once the inflammatory cytokine attaches and there is signaling happening inside the cell to the nucleus, this is where we go and interfere with the JAK inhibitors. So the small molecules, and there is now a horde of them coming in. You will have now them in psoriatic arthritis, TYK2 inhibitors, JAK1 inhibitors, JAK2 inhibitors, pan-JAK inhibitors, and new molecules like Bruton kinase inhibitors. So they have revolutionized the field. And with just a pill today, we are able to very aggressively control the disease. But the problem in our country remains infections. In our country, patients do not die of rheumatological diseases, they die of infections. And infections are everywhere. We have seen that in COVID. You develop mucormycosis, not because mucormycosis was never there in our country. It's always there. It's in the leaves where the defecation of the dogs and cats. But we are inhaling, we are fine. The moment our immune system goes down, we catch infections. So it is very important to use them judiciously and make the patients aware of infections. So a lot of people, when we use steroids, we give them PCP prophylaxis, we are putting them on bisphosphonates, give them adequate vaccinations. So pneumonia vaccinations, influenza vaccinations, and now, of course, the herpes shingles vaccination. These are very, very important. So preventive measures today are also equally important when we talk of treating these patients.
Thank you, Dr. Nath. I think, but there is very important query in my mind which keeps hampering me. And I often discuss it even with Yash also. And this query is very close to my heart, that our strength in alternative system, especially in Ayurveda, etc., and especially in the field of arthritis, pain and all, where we feel that they are perhaps trying to give strength to our muscles and bones, and which perhaps if they are strengthened from outside, it may definitely give a better relief and cure to our patient. So my question to Yash, you are there?
Yes, yes.
Yes. So what do you think is a complementary role of a Ayush system, which basically I'm talking of Ayurveda?
I personally think that alternative medicine has definite role to play in time to come. The only caveat is that it has to be in a more scientific manner. You see, what allopathy has done and where it has scored more is that they've done trials, they have done that this works, this doesn't work, this has this side effect, it works in these circumstances. So this is where the alternative medicine like Ayurvedic, homeopathy, and we are witness to many diseases, like with homeopathy, the warts, they disappear with one drug within a few days. We have seen it a number of times.
Yes.
With haldi, we have seen you apply it and it does have anti-inflammatory property. And there is a group of orthopedic surgeons I know in Agra, and they told me that we had pain and we started taking this turmeric tablet, in capsules and not even oral, and we felt better. So all these things are anecdotal, but we need to have trials to say, okay, this type of arthritis, this treatment was given and this was the result. And after all, I mean, there are many drugs in allopathy which is derived from plants, but they've done trials. So that's where I think to sum up my answer to your question is that I'm a believer in holistic medicine. No question in mind, but it has to be more scientific to tell us, look, it will work here and this will not work here. Unfortunately,
So,
most of the alternative medicine have very little side effects. Only thing is that some people, they are adding steroids and unwanted things into these medicine and giving to the patient without telling exact contents. So that is again bringing a bad repute to science, which can actually be very helpful in time to come. And it has been helpful in time immemorial before empathy came into its own. So my answer is that we need to believe in it, but we need to work towards getting it more scientific and combine a holistic approach.
Sir, if I may add into that, so I was part of this trial called the NIMTILI trial. This was the multi-center trial done in All India Institute of Medical Sciences, our center in Nizam Institute of Medical Sciences, Hyderabad, and 2 other centers where the rheumatoid patients were either, triaged to take allopathy, and if they did not want, they went to Ayurvedic. And we had a simultaneously Ayurvedic medicine doctor. The result of the trial was that Ayurvedic medicines do work in mild to moderate disease, not in severe disease. But the myth that was broken was they also have side effects. They have side effects on the liver, they have side effects on the kidney, and that need to be monitored because a lot of these drugs can contain heavy metal, which can be toxic. So they do work, but do not work at a very refractory conditions or difficult to treat patients. And they will need monitoring how that needs scientific deliberation. But it is not that they are absolutely safe and they don't have side effects. So the important thing is not that the drugs that we use are, so a lot of patients ask that your drugs are not safe. Nothing is safe. Even paracetamol is not safe. The question is, once you're taking a drug, we must know what are the side effects and how to monitor them. That is important. A devil in bush is better than 2 angels, a devil in hand is better than 2 angels in the bush. So it's important to know what medicine you're using, what are the possible side effects, and how to monitor that.
Absolutely correct. That we must know what we are taking.
Yes.
We must know. I think as regard my observation is concerned, as regard Ayurveda is concerned, there are 3 important components. One is the pharmaceutical intervention, which we are not very sure what are the side effects, but intervention which is they call surface therapy and panchakarma, which are relatively safe, and if they bring enough evidences of some relief or cure, then there is no harm in. But I'm very, very particular regarding pharmaceutical intervention. We must know what is the medicine, what are the side effects before we, of course, we have no right to prescribe them. They are expert, but that is what our query is. So that brings the end of the discussion. Wonderful discussion among 3 of our experts. And is there any query, Tiwari-ji? Tiwari-ji? तिवारी जी अपने को अनम्यूट कर लीजिए.
There is a question from Minu Bhargava, Calcutta. From Dr. Gulati. Am I audible?
Yeah,
Am I
डॉक्टर
audible?
गुलाटी हैं हमारे पास. आप बिल्कुल, we can hear you.
डॉक्टर गुलाटी जी, आपने बहुत ही वंडरफुल काम किया है अपने सब्जेक्ट में. वो जानना चाहती हैं कि आजकल रोबोटिक सर्जन का एक दौर चला हुआ है और वो थोड़ा कॉस्ट इफेक्टिव भी है. तो क्या ट्रेडिशनल मेथड से वो टेक्निक अभी उसको एक्सेप्टेंस उसका कम हो गया है या उस टेक्निक के रोबोटिक का उसकी पूछ कम हो रही है, क्योंकि हर कोई अफोर्ड नहीं कर सकता उससे कीमत कॉस्ट को. आपका क्या कहना चाहेंगे किसी भी न्यू रिप्लेसमेंट के लिए?
देखो, मेरा विचार ये है कि मैंने जैसे पहला भी एक फ्रेज बोला था कि यू हैव टू रन टू बी एबल टू स्टैंड, कि अगर आप टेक्नोलॉजी के साथ हाथ नहीं मिलाओगे तो आप पिछड़ जाओगे. क्योंकि आज से 25-50-100 साल पहले कोई सिर्फ रिप्लेसमेंट की बात भी कहता था, कहता ये कैसी बातें कर रहा है, और आज से कुछ साल पहले कोई कहता कि जेनेटिक कोई चेंज कर देंगे और डिजीज कंट्रोल कर लेंगे, बोलो कैसी बात कर रहे हैं. तो टेक्नोलॉजी तो आपको हाथ मिलाना पड़ेगा, और टेक्नोलॉजी को लेकिन कैसे यूज करना है वो बहुत महत्वपूर्ण है. लेकिन मैं इनको रीएश्योर करना चाहूंगा कि रोबोटिक के बिना रिप्लेस किए जाते हैं, दे आर वंडरफुल. पिछले 25 40 45 50 साल जो नी रिप्लेसमेंट हो, खुद पिछले 30 साल से मैं कर रहा हूँ, द रिजल्ट्स आर एब्सोल्युटली ओके. दे आर नाउ रोबोटिक इज जस्ट ट्राइंग टू इम्प्रूव इट अ लिटिल बिट. तो वो भी अभी टाइम बताएगा अगले 10 15 20 सालों में कि क्या एक्चुअली इसने उसको इम्प्रूव किया कि नहीं किया. तो अभी ऐसा लगता है दैट इट इज इम्प्रूव. अभी जब हम उसको करते हैं तो लगता है हाँ हम स्क्रीन पे देख रहे हैं, हम इतना एंगल चाहते थे, इतनी ये चाहते थे, इसके अंदर लैक्सिटी आ रही है, वो हम स्क्रीन पे देख रहे हैं. लेकिन ऐसा कुछ नहीं है कि अगर रोबोटिक नहीं है तो आपका रिप्लेसमेंट अच्छा नहीं होगा. इट्स अ फैंटास्टिक ऑपरेशन इवन विदाउट रोबोटिक. पर अगर है तो टेक्नोलॉजी के साथ जाना चाहिए, इसमें भी कोई डाउट नहीं.
Thanks a lot. Dr. Garima Mahajan, Patel Nagar, New Delhi. This question goes to Dr. P.D. Rath.
जी.
Am I audible, Dr. P.D. Rath?
हाँ जी,
Yes,
बोलिए.
yes.
सर आप ये बताएं कि रूमेटोलॉजी के जरिए आपका क्या टेक्निक होता है किसी भी बैक और हिप पेन को ठीक करने का, सरल शब्दों में आप बताएं.
हाँ, तो बेसिकली ये है कि हिप और बैक पेन का कारण क्या है. और ये जो हिप और बैक पेन का कारण अगर इन्फ्लेमेटरी पेन है, आर्थराइटिस इन्फ्लेमेटरी है, रोमेटॉइड है, या बैक में एंकाइलोजिंग स्पॉन्डिलाइटिस है, तो इसके लिए हमारे पास दवाइयाँ हैं जिसको हम कहते हैं डिजीज मॉडिफाइंग एंटी रोमेटिक मेडिकेशंस. और ये दवाइयाँ जो हैं ये डिजीजेस को पूरी तरह कंट्रोल करती हैं, बहुत अच्छी तरह कंट्रोल करती हैं. अब अगर ये पेन्स मैकेनिकल पेन्स है, ऑस्टियोआर्थराइटिस है हिप में, या फिर स्पाइन में डिजेनरेटिव आर्थराइटिस है, तो अगेन ये डिपेंड करेगा कि ये डिजीज माइल्ड है, मॉडरेट है, सीवियर है, पेशेंट का एज क्या है. और जैसे कि डॉक्टर गुलाटी ने और डॉक्टर राजगोपाल ने डिस्कस किया, अगर पेशेंट्स बहुत यंग हैं, अर्ली स्टेजेस ऑफ डिजीजेस में है, तो फिर कंजर्वेटिव ट्रीटमेंट से ही इसे कंट्रोल किया जाता है. और अगर ये पेशेंट्स एडवांस डिजीज में आ गए हैं, उनकी एज ज़्यादा है एंड दे आर एडिक्वेट आइडियल कैंडिडेट्स फॉर सर्जरी, तो इन्हें सर्जरी ऑफर करना चाहिए.
You may to say first of all they contact you, then go to the orthopedic surgeon.
डेफिनेटली आई वुड डेफिनेटली से दैट बिकॉज बहुत से पेशेंट स्पेशली जो यंग लोग हैं उनको बहुत बार इन्फ्लेमेटरी पेन होता है, या आर्थराइटिस जो होता है वो नॉन इन्फ्लेमेटरी भी हो सकता है, इन्फ्लेमेटरी हो सकता है. ये डिफ्रेंशिएट करना सबसे पहला काम है. और एक बार ये डिफ्रेंशिएट हो जाता है, उसके आगे का रास्ता बहुत साफ हो जाता है कि उनको किस तरफ जाना है.
Dr.
Tiwari
Gulati,
ji,
do you agree with me? Robotic surgeon is very cost effective.
No, I won't say it is cost effective. It is more costly, no question about it. But इतना भी ज्यादा costly नहीं है. See, depending on various institutions, it may be for one knee may cost about 50,000 more, and for two knees about 1 lakh more. The problem with this is that many insurance companies are not covering it. So that's where is a challenge. And there are some insurance companies who actually pay much less if we do surgery with robotics. I don't understand their logic, but that's the way it is. I mean, they'll pay, say, about 30-40% of the bill they will pay for without robotic surgery. I don't understand the logic, but this has to be worked out, you know. So technology has to be imbibed, technology has to be encouraged. There is this insurance companies also have to understand this.
ये
So you
मैं
people
पूरी
are
एग्री करता हूँ आपसे गुलाटी जी. जब हमारे पास टेक्नोलॉजिकल एडवांसमेंट हो रहा है तो पेशेंट के एक्सपेक्टेशंस एंड पेशेंट भी चाहते हैं कि जब हम अच्छी तरह इंश्योर्ड हैं तो हमको बेस्ट पॉसिबल एडवांटेज क्यों नहीं दिया जा रहा है. Nobody wants to compromise second best.
No, so
If
they, I mean,
clinically indicated, everybody deserves the first best, right?
everything comes at a cost, and
But at the same time, the insurance companies should have a policy of improving their entire SOPs,
and,
changing their SOPs to in the best interest of the patient.
I mean,
Because believe me,
I found it absolutely illogical approach. They must be having some reason which I do not understand.
I think here comes the role of clinicians altogether. I mean, if we all put our foot down, they can't do anything. That is the strength of clinicians.
Yeah.
तो तिवारी जी, आई थिंक टाइम बहुत हो चुका है, हमने
Yeah.
ओवरशूट कर चुके हैं. मैं सबसे पहले तो थैंक्स कहना चाहूँगा अपने सब कोलीग्स को जिन्होंने आज मॉर्निंग से अपने को ज्वाइन किया। ऑफकोर्स डॉक्टर अशोक राजगोपाल जो अभी ऑपरेट करने चले गए, डॉक्टर यश गुलाटी एंड डॉक्टर रथ से भी मेरी मुलाकात एथिक्स कमेटी के प्लेटफॉर्म में होती रहती है। एंड वी हैड वंडरफुल डिस्कशन। तिवारी जी, ये रिकॉर्डिंग बहुत इम्पोर्टेंट है, उसको आप जरूर, और जो यदि और क्वेरीज हैं वो आप या तो अपने आप या मेरे थ्रू इनको भिजवा दीजिएगा।
बिल्कुल,
एंड
और मैं आपको तहे दिल से शुक्रिया करता हूँ इस वेबिनार में शामिल होकर। आशा करता हूँ आगे हम कंटिन्यू करेंगे और आपका कंट्रीब्यूशन मिलता रहेगा। धन्यवाद। थैंक यू सर।
और मैं
थैंक यू।
आपको भी और आपके सिस्टम को भी धन्यवाद देना चाहता हूँ। डबल हेलिकल एक ऐसी मैगजीन है जो पिछले कुछ सालों से ही बहुत अच्छा उसने रेंज कवर कर लिया है, एंड इट इज मेंट फॉर प्रैक्टिकली ऑल कैटेगरीज ऑफ expert, even experts or those young doctors, and even for the public. So
थैंक यू
thank you.
सर। थैंक यू ऑल ऑफ यू। थैंक यू। नमस्कार।
Thank you.
Yes. Thank you, Dr.
Thank you,
Raj.
sir.
Sure, thank you.
Have a nice
And
day.
thanks to everybody of
हैव अ
Double
नाइस
Thank
डे।
you.